Go ahead now.
So, good evening, everyone, and a very warm welcome for today's Facebook Live session. I'm Dr. Sayali. I'm the junior consultant and fertility specialist at Oasis Fertility Pune at the Kharadi Center. And our topic for today's Facebook Live session is all you need to know about tubal testing. Now, tubal testing or these tubal patency test is usually advised by a doctor if they, want to test for the tubal factors or if they suspect any blockage. Now, these tubal factors are responsible for almost 15% of the females that are visiting our, infertility clinics. So, tubal patency is one of the very important factor that is responsible for conception. So as we know that tubes are responsible for the process of fertilization, it is responsible for the migration of the fertilized ovum into the uterus, and therefore a healthy and patent fallopian tube is one of the absolute requirement to attain pregnancy. Amongst the other important things, as we know, is that the female should be a normal ovulating female, and she should have regular menstrual cycles and a good ovarian reserve. The uterine lining, that is the endometrium, should be adequately developing, and the husband's semen analysis should be within the normal limits. Now, coming to this tubal factor. So, tubal factor infertility, one of the very common, reasons for, tubal affection or tubal blockage is the pelvic infection or the pelvic inflammatory diseases. And here, the fallopian tube, as we know, play a very important role in the pickup of the egg after ovulation. It helps in the transport of the egg to the fallopian tube. Here, the sperms meet and they result in the process of fertilization. And when this fertilization occurs, the resultant embryo is then transferred into the uterus. And therefore, this healthy and a patent fallopian tube is an absolute requirement when it comes to, getting an intrauterine pregnancy. Now, when it comes to tubal blockage can be of two forms. It can be either a complete blockage or it can be a partial blockage. So, when it is a complete blockage, the eggs and the sperms will not be able to meet and there'll be no fertilization and no pregnancy will occur. But when there is a partial blockage, maybe the sperms can reach the egg and result in fertilization, but the embryo that is formed, it gets trapped inside the tube and it results in something which is known as the ectopic pregnancy. Now, as we have seen that the most common cause of tubal blockage is going to be infections. And when we want to test for this tubal factor, there are various tubal patency tests that are available. And of these, the commonly used tubal patency test is going to be the HSG, that is the hysterosalpingogram. Then we have various tests which are done under sonographic guidance. In that we have the SSG procedures or the gold standard or diagnostic tests such as laparoscopy. Now, all these tests are usually done post-menstrually, that is usually on the day 6 to the day 10 of the menstrual cycle. Now, why is it so? That is because if the woman ovulates early, there is the possibility of pregnancy. And therefore, we do not want to disturb this potential pregnancy that might occur. Or if the woman is pregnant, then this might also alter the migration of the resultant embryo into the fallopian tubes. Uh, Now, these tests of tubal patency, as we know, are usually done from the day 6 to day 10 of the menstrual cycle. They are not done in presence of bleeding, or they are not done in presence of any active infections. Now let us deal with the very common test of tubal patency that are usually done. So first we have the HSG, that is the hysterosalpingogram. Now, this test, as we know, is also done in the day 6 to day 10 of the menstrual cycle. Now, in this, we have a small catheter. This is going to be passed through the cervix into the uterus, and then we have a water soluble radio opaque dye is instilled through this catheter, and then this dye is going to pass from the uterus through both the fallopian tubes, and then it is going to spill out of the femoral end of the fallopian tubes into the peritoneal cavity. Now, this is something that is seen when the tubes are patent, and to have a view of this, we will take serial x-rays or radiographs will be taken. Now, in terms of patency of the fallopian tube, we will check that the dye has filled the entire fallopian tube and it has spilled out into the peritoneal cavity. But if there is any blockage, there'll be accumulation of dye at that particular point, and the dye will not be able to cross beyond that point. Or if there is, accumulation, I mean, if a large mass is formed and the dye is accumulated at that point, then this can also indicate the presence of the hydrosulfates. So HSG will help us in detecting whether the tubes are patent or if there is any blockage. It will help us in detecting the exact site of the blockage, and it also helps us to detect if there are any problems in the uterine cavity, as in if there are any malformations in the uterus, or if there are any fibroids or any polyp. This all also can be, visualized under the HSG. Now, as what are the drawbacks of HSG? Now, HSG here, a radio opaque material is passed through a cannula, so this procedure can be painful. So when this procedure is painful, it results in spasm at the corneal end of the fallopian tube. So this can result in a false negative test. And sometimes when this procedure is not done properly, then also, we will not be able to see the flow of the dye. So the inaccurate procedure, so this procedure is not very accurate. The sensitivity or specificity of the HSG is not very good. So in cases where we are, seeing a corneal blockage, that can, may not be an actual blockage. That can, be because of some mucus plugs or debris that are present, or it can be because of, inadequate procedure, or it can be because of corneal spasm. And therefore, when we see some blockage to HSG, that needs to be confirmed by a laparoscopy. Then again, this procedure does cause pain. It can, in very few cases, it can result in infection. And so the next procedure that we are going to deal with is the SSG, that is the sonosalpingogram. Now, there are certain procedures. In SSG, what is done is a saline or some contrast medium is going to be instilled through a catheter into the uterus, and this contrast medium or saline is going to travel from the uterus to the tubes, and then they're going to spill into the cavity. So in an SSG, we will see the accumulation of the fluid in the peritoneal cavity. And all this is seen under ultrasound guidance with the help of a transvaginal probe. So as we see that SSG procedure as compared to HSG is less painful. Now here, we may or may not give any anesthesia or a sedative for this procedure, but this procedure is definitely less painful than the HSG, and therefore there are less false negative cases, that might occur because of the corneal spasm, as we have seen. SSG also helps us in detecting if there are any abnormalities in the endometrial cavity, as if there are any adhesions, if there are any polyps, any uterine malformations. All of these things can also be monitored with the help of SSG. In terms of specificity and sensitivity, SSG is almost as similar to HSG, but it has lesser false negative cases because there is lesser amount of pain and lesser amount of corneal spasm. Now, what we have dealt is with HSG and SSG. Now, the gold standard or the most accurate test is laparoscopy. Now, what happens in laparoscopy is a small laparoscope or a telescope is inserted into the abdomen through a very small incision at the umbilical level, and with the help of this laparoscope, we will be able to visualize the entire abdominal cavity or the pelvic organs. Now, here we will be able to visualize the uterus, the tubes. We will be able to see the ovaries. We will be able to see if there are any adhesions, if the tubo-ovarian relationship, as we know that the tube is a connecting link between the uterus and the ovaries. And therefore, if the relationship between the ovary and the uterus is affected, then maybe the egg will not be picked up, or the transport of the egg will be affected. So it will help us to evaluate that. It will help us to evaluate whether there are any abnormalities in the tubes, as in the form of if there are any nodularities, any beaded form, or any site of infection. Now, all these things can be visualized with the help of a laparoscopy. And laparoscopy will also help us to establish the tubal patency. Now, in this, a saline or a methylene blue solution is passed through the cervix, and the spill of this out of the fallopian tubes to the femoral end will be directly visualized, under a laparoscopy. And therefore, this will give us like a more, a diagnostic confirmation whether the tubes are patent or not. Again, when we are going ahead with a laparoscopy, if there is any problem with the tube or if there is any blockage, we can also go ahead with a therapeutic procedure, and we can clear the blockage if it is possible. Now, so these were the very common diagnostic tests that we have done. So as we have seen that the most commonly used is the HSG, but as HSG is little painful and the patient might not be able to tolerate it, so an SSG procedure under sonographic guidance and under anesthesia will be more comfortable to the patient. Okay. So this is all that I have from my side, and I hope that this has made you better understand this topic. Now we have a few questions which are coming over from the viewers that we will answer. So we have a question from Rama Lakshmi: is if we have slow flow in the fallopian tube, is it suggest to go for IUI because I have two failed IUI? Can I go for the next IUI? So definitely, as we know that if there is a slow flow to the fallopian tube, there might be some problem with there might be some form of partial blockage with the tubes, and or there might be some abnormality with the lining or the mucosa of the tube. So in that case, if you have two failed IUI, I would suggest you to go for just one more cycle of IUI. And if you're not able to attain pregnancy, but obviously as we know, if there is a slow flow, there can be some partial form of blockage, and in that case there's a chance of ectopic pregnancy. So keeping that in mind, maybe one more cycle of IUI can be tried, and then you can go for the further procedures in terms of IVF. Okay. So next question we have is how common is tubal factor infertility? So as we know, it's around 15% of these females who are visiting do have some problem with the tubes. So it's going to be around 15% in the overall thing. The next thing is what causes tubal damage. So there can be various causes that can result in tubal damage. One of the most important cause, as we have mentioned in this session, is going to be any form of pelvic infections. Pelvic infections that are caused by chlamydia or gonorrhea can result in this, tubal damage, and that can affect the anatomical and functional patency of the tube. Then there can be some amount of tubal blockage that can also result if there are any operative procedures that are undertaken, like recurrent miscarriages and DNE procedures that have been undertaken, or if the patient has gone for a tubal sterilization procedure and has done a tubal reversal, maybe the mucosa of the tube may be damaged in this case. Okay, so the next question we have is, can proximal tubal occlusion be cured? So as we have seen that the fallopian tube is usually divided into three segments. That is going to be the proximal end of the fallopian tube, the mid segment, and the distal. So the proximal tubal blockage can be because of corneal spasm, or it can be because of some mucus plugs or debris that are kind of collected in that area. So definitely we can give it a try by laparoscopic cannulation to cure the proximal tubal blockage. And the success with a proximal blockage is more than a mid segment or a distal tubal blockage. Okay, so next is, are there any signs of blocked fallopian tube? So coming to the signs of blocked fallopian tube, specifically if the patient is not able to conceive, or if you are able to see any abnormalities on the sonography, as in a dilated tube with a fluid that is collected, like a hydrosalpinx can be one of the cause, where the fluid is not able to drain out and it gets collected. So that can be one of the cause, or factors like such as endometriosis or anything. If other factors are suggesting, there can be adhesions that can affect these tubo ovarian relationship, and that can also be a cause of blockage of the fallopian tubes. Okay, so I think this is all that we have. So thank you for patient hearing. And I would like to conclude my session out here. So if you people have any queries related to this topic, or any other doubts, you can dial the helpline number that is given below, or you can reach us physically at any of our center, that is Oasis Fertility at Kaspati Vasti Vakar or at Arza Avenue, Kharadi. So thank you.